Hello, my name is Fiona Chaabane and I'm a consultant Admiral Nurse. I work as a clinical nurse specialist in younger onset dementia and Huntington's disease, and I'm based at the Wessex Neurological Centre at Southampton General Hospital. My role is to try and support those diagnosed with younger onset dementia or rare dementia, and most of my work is done in the community, assessing and monitoring people in their own homes and on a long-term basis from the point of diagnosis, or in some cases before diagnosis is confirmed. So a little introduction to the session. I really hope that after this session you'll have a slightly greater awareness of some of the conditions that are most often seen in younger people, what impact the diagnosis can have on younger people and their families, and ways of working with the person with dementia and their families on a long-term basis. This is by no means an in-depth presentation, but I hope it gives you some food for thought and is of interest and stimulates some discussion for later. So what do we mean by younger onset dementia? What's the difference? Isn't it just dementia? Isn't it dementia about losing your memory? What's the difference in young people? Well, let's have a look at some of the differences. So nothing happens when we get to 65 in terms of diagnosis. The cutoff for over and under 65 merely reflects administrative cutoffs of working age people and people of retirement age. At least that was when we used to retire at 65. In fact, the pathology that Dr. Alzheimer was writing about was in fact his findings of changing pathology in the brain in a 51-year-old female. So it was a process over time that led us to think that Alzheimer's disease is something that occurs in older people only. Dementia in a younger person is more likely than in an older person to have a genetic cause. I'll discuss this in a few minutes, but the illness being due to a faulty gene is higher at risk the younger you are. And just run through this slide. The largest group of people affected in this age range are those generally in their 50s. A smaller group of people are affected in their 40s and 30s and can affect people much younger than that. My youngest patient was 28 years of age. Alzheimer's disease is thought to be the most common pathology, so statistically the most diagnosed condition, but the range of diagnoses is greater in younger people than in older people. So the older you get, the fewer diseases you might be looking for. The younger the person is, the longer the list of illnesses that could be causing the person's symptoms. And the younger you are, you're much more likely to be diagnosed with a genetic disorder or a less common form of dementia. And crucially, symptoms often show at a time when there's the highest lifetime burden. For example, you're in work, raising a family, caring for older parents maybe, personal and financial commitments and responsibilities. So here are some examples of dementia commonly seen in young people. So as I said earlier, Alzheimer's disease, statistically the most common diagnosis, but often a very different presentation from what you might see in older people. For example, in older people, Alzheimer's disease often presents with memory difficulties at first. That's not often the case in a younger person. They will be affected by memory changes in due course, but that's generally not the first things that people notice about the person who's affected. There are frontotemporal lobe symptoms. For example, this is just a list of acronyms, but behavioural variant, frontotemporal dementia, semantic dementia, primary progressive aphasia, progressive non-fluent aphasia. This is just a few of the subtypes of frontal lobe dementia, and as technology progresses, we're now able, in most cases, to differentiate between these particular conditions, although I have to say that takes a lot of expertise and equipment and is very difficult sometimes to separate one condition from another. In frontal lobe conditions, personality and behaviour changes are often very marked and may be the first sign that something is wrong. Lewy body dementia, or dementia with Lewy bodies, and Parkinson's syndromes. There's a couple there, progressive supranuclear palsy and cortical basal degeneration, are also in this group. So Lewy body dementia is very important to clarify if this is the case, if this is the diagnosis, because treatments that we use for Alzheimer's disease sometimes and frontotemporal dementia can make Lewy body disease worse. Vascular dementia, This is caused by a change in the blood flow to the brain, such as a stroke, or a long-term outcome from the build-up of matter that can narrow the arteries. So in either case, the blood flow to the brain or to part of the brain has been restricted either suddenly because of a sudden stroke or gradually over a long time, that the area supplied by narrowed arteries and blood vessels doesn't get the amount of oxygen that it should and doesn't function so well. A few more for you. Huntington's disease. It's an inherited condition and is in fact a movement disorder featured with involuntary movements that can affect most of the people who are suffering from this disease. But it ultimately results in often cognitive and behavioural changes and ultimately a dementia. There are often significant behavioural changes in this condition and dementia results at the end of the process. There are prion diseases, for example, CJD, and another one here, Gerstmann-Strauss-Schenker GSS disease. These are formed from an excess of a prion protein in the brain. And I'll just digress a little bit. You may all remember mad cow disease in the late 80s. That was a prion disease entirely created by man and a change in farming habits, but it was caused by an infectious prion protein. So it's referred to as new variant CJD. It killed 131 people in this country, and very interestingly and sadly, sometimes the main presentation of the person being affected by this at the very beginning was a change in personality. So some people were misdiagnosed for quite some time, although the illness progressed very quickly. It's all stopped now, apparently. Mad cow disease, there is still CJD about, but that's not caused by the new variant. So that's not an infectious cause. That's called sporadic CJD. And we should all look out for possibility of CJD where a person with dementia's condition deteriorates really quickly and there's no other obvious cause for that. And as I touched on earlier, there's a higher likelihood of a genetic disorder in the younger you are. For example, TDP43, don't need to remember these, but C9orf72. These are all hereditary causes of a dementia presentation, sometimes frontal lobe type presentation, sometimes Alzheimer's disease. But as I said earlier, as technology improves, we're more able to pick up these genetic mutations that can have an implication for children and indeed siblings of somebody who's affected. This is just a slide of some of the possible differences related to the age of onset, and they're sweeping generalizations, but if you look at late onset dementia, mostly the person affected will be perhaps retired or nearing retirement age, less likely to be caring for children or young adults, less likely to be caring for the older generation, and may have fewer high demand financial commitments or responsibilities. As I say, sweeping generalization. There are many retired people who have loads of commitments and are actively caring for younger and older adults. But in general terms, we would expect people of retirement age to be slowing down somewhat. Younger onset dementia, the person is likely to be in work or struggling to stay in work, so there may be capability issues that the person is experiencing, or they may be coping with disciplinary issues at work because of their poor work performance. That's a very common scenario. They're much more likely to be living with or be a provider for children, more likely to be caring for older relatives, and may be responsible for the mortgage, the rent, maybe the main wage earner, and maybe heavy financial commitments, loans, credit cards, and all of that may be related to stress that we all experience, I suspect, in midlife. There's a few more thoughts for you. Mainly, older people may have a slower pace of life after retirement, or be reducing their work hours to part-time or a kind of less demanding role. The older you are, the less likely you are to be responsible for employees or to be working in a precise work environment. And you're more likely as you age to have physical health challenges. Younger people, on the other hand, may be becoming more complicated, their life may be becoming more complicated as family life and work commitments evolve. They're more likely to be driving heavy machinery, building operating machinery, managing groups of people, balancing accounts and financial responsibilities. And they're less likely to have other health problems, like to be physically strong or more robust. Now, as I said before, these are sweeping generalizations, but when you think about what you're doing in midlife, perhaps when dementia might present itself, you're probably quite busy with life and all of its commitments and work commitments too. So what's the impact? These are just a couple of comments that people with younger onset dementia have said to me. I had no idea. I just thought it was all about work. So this is a person who was quite shocked to find they had Alzheimer's disease and had for a long time thought that their difficulties were about work, nothing to do with an illness of any kind. They didn't have the insight to spot of the difficulties that were being caused for them at work. My manager said I wasn't performing right. I had to stop work. This again kind of reflects the person's lack of insight. They're not able to understand that they may be struggling at work and say things like this. My manager said I wasn't performing right. I had to stop. Very distressing. I can't find another job. I can't focus to do any work, and now we've got no money. This is very common in younger people with dementia, as that work disappears, dries up at some point, and they may be left with no income at all. This is a very, very difficult scenario to deal with. I'm fine. The doctor said everything was fine. That's again linked with the first two. These are all from different patients, but all at the similar stage of not being able to understand their own condition. The doctor said everything was fine. I think that's unlikely in this particular person's case. And this is, I have to write everything down in my diary, everything I've done, everything I eat and drink, otherwise I can't remember if I've done anything. This is a man who did write everything down in a very large diary, so if he spoke to anybody, if he eaten anything, if he made himself a drink, had cups of tea, coffee, went out, he would write it all in the diary because he wouldn't be able to retain it. That was fine until he became separated from the diary when they went on holiday and left it behind, and he was very, very distressed and very, very under a great deal of stress because his diary, which formed his life, wasn't available. I think everyone's just overreacting. This is nonsense. Again, that joins up with the first couple of statements. This is somebody who was quite sure that the doctor had made the wrong diagnosis. It was all rubbish. This is nonsense. There's nothing wrong with him. And this reflects a lack of insight that actually all people with dementia experience at some point. But in younger people, it tends to happen fairly early on in the condition. So what's the impact on immediate family? I'm watching him change, like one light going out after another. Each time a light goes out, I lose a bit more of him. That was the wife of the man with the diary. He'd be mortified if he realised how he's treating us. Maybe he can't stand me anymore, but I can't forgive him for the way he is with the children. This kind of reflects a piece of work to do on the fact that the person's behaviour is changing and that it's not deliberate. He was not treating them that way on purpose, and the wife was struggling here to understand why he was behaving in such an antisocial and horrible way towards the children that, as she put it, he used to love very much. He hasn't got any idea how to behave. Keeps telling women that they're beautiful. He doesn't know how to behave. It's embarrassing. This is a very common feature of frontal lobe conditions, frontotemporal lobe conditions, and not being able to conform to social boundaries is a very marked and problematic feature for some people. So these are people who will walk to the front of the queue to get stamps at the post office and not see there's a queue of 10 people before them. These are people who are not able to recognise perhaps behaviour or social boundaries. You might think somebody is beautiful, but you don't go up and tell them necessarily. The person with this kind of problem is not able to acknowledge social boundaries, and that can be quite difficult to manage. The children can't stand it now. They can't wait to leave home, and they stay with their friends as much as they can. Again, very common when younger children are involved, that they don't want to come home. They don't want to invite their friends home. They like to stay with their friends somewhere else, and they take any opportunity to stay out late. And I can think of one couple in particular where the child stayed out late and took up drinking cider in the park rather than go home. So got in with the wrong crowd, a very tense and difficult situation for everyone to manage. He goes out and I've no idea where he goes, and he doesn't either. He won't stop driving and he isn't safe. Again, reflecting a lack of understanding or insight into the fact that the person really shouldn't be driving. People with frontal lobe problems in particular will think that it's everybody else's problem and there's nothing wrong with them at all. Impact on parents, wider family and friends. This is something we don't often come across in older people's services, although of course we do from time to time. Parents said to me, did I do this to her? She got it from me, is it my fault? Imagine what you need to unpick with that parent watching their child fail. I can't believe how she's behaving. We didn't bring her up like this. She was always polite and respectful. She didn't swear. Now she swears all the time. It's horrible. This is from a parent watching their daughter change significantly and become somebody who wouldn't in the past have behaved in that way. It's very difficult for parents to come to terms with that. I asked his brother to have a word with him to get him to snap out of it, but it hasn't worked. He's ignoring everyone. Many people don't recognise that lack of insight is a huge problem. People will often refer to the person as being in denial. Denial is understanding a situation, having the information in your reach. You've made a decision not to discuss it or not to act on something, having weighed up all that information. In dementia, the person isn't able to weigh up that information. So they just don't understand. There's a small part of their brain that doesn't know that they're ill. So they come across as ignoring everybody, not doing the right thing, and their lack of insight can be very, very destructive. Parents here, we're helping them out financially, but I don't think we can do that for much longer. We're running out of money. But I worry about the grandchildren all the time. Imagine the dilemma for that family who are trying to support the person with dementia who no longer works, and their partner and 4 children. I remember this particular case, and everybody was running out of money. How do you survive? You never think your child is going to go before you. It's like watching a slow motion car crash. I can't come to terms with that. So I hope those sentences, those statements from people affected by dementia, those nearest and dearest to them, gives you an insight into some of the issues that they're facing. There's a campaign, isn't there, in Dementia UK about if you know somebody with dementia, then you're living with it too. And that's really very true. Family and friends, it doesn't just affect the person with dementia. This is a whole family system. Support before and after diagnosis, a few thoughts here. Nobody expects a diagnosis of dementia. This is one of the reasons why it can take so long to get a diagnosis. Some people have to, in fact, wait 2, 3, 4 years, even longer sometimes, before the diagnosis is concluded. So why is that? There's a couple of reasons, but one of them is that first sentence, in a younger person, no one expects a diagnosis of dementia. So if a person with cognitive problems who's younger goes to a GP or a specialist and says, I'm struggling at work, I can't do this, I can't do that, my memory's terrible, their first thought is likely to be that that person's under stress and that it's likely to be as a result of work or midlife burdens. So, for example, having financial burdens, dealing with young children, families, and all of the day-to-day stresses that I'm sure most of us experience. Most people will attribute changes in the brain or changes in the person's performance to life being just very difficult at that time of life. Investigations can be complex and not always available locally. So the scans that are needed, the expertise that's needed to investigate and diagnose younger onset dementia may be in a specialist centre. And it may take a long time to get access to the appropriate treatment. And that's not necessarily because nobody's looking for it. People who present with cognitive problems and mood problems in middle age, as it says in the statement above, will probably be sent to or attributed to be the menopause or depression, anxiety, and those sorts of things. And that adds delay to identifying the right diagnosis. We do need to help the partner, the family, to stay well, including children. They're a very vulnerable group, and there's a lot of research that shows that partners of people with dementia suffer maybe later from different diseases, and they're very much more vulnerable to infections and stress and stroke and those kinds of things. So the family living around the person needs to be monitored, in my view, quite closely and supported to help deal with their own health needs and to keep an eye on their own well-being, which is very difficult when you're managing somebody who may have very high demands on your time. The diagnosis will always come as a shock. I've seen several people come out of an outpatient clinic having been told, for example, they've got Alzheimer's disease, and they've said to me afterwards, "Thank goodness, I thought he was going to say it's dementia." So even if people think, or they're coming to clinic thinking, I'm thinking this might be a dementia, it's still a shock. It's still a shock to anybody to be diagnosed if they're younger. It's a shock at any point in life. But in younger people, most people aren't expecting that. They may have heard about it, they may have read something about it, but they're probably not expecting that to be the diagnosis. So there's time to support them, starts from that point of diagnosis, if not before, to consider what that conversation was about, what the diagnosis means, and to be pointed in the right direction in terms of long-term support. There isn't a younger onset dementia service, so where does the person go for help? Good question. Younger onset dementia is not the diagnosis. I need to clarify this. It's a syndrome. So people need to know about their particular dementia. So no doctor will ever say to somebody, "I'm afraid your diagnosis is younger onset dementia." The diagnosis will be Alzheimer's disease or frontotemporal dementia or something like that, which falls under the umbrella of younger onset dementia. But it's important to remember that's not the diagnosis. The diagnosis is whatever their condition is, and people need support to understand and know and to link in with expertise about that particular condition. Long-term contact with health and social care professionals is essential because the condition is neurodegenerative. It will continue to progress. In and out, what I call in and out care, so a brief period of care and then discharged or case closed, I think is not helpful, although I do understand people need to work to different timescales and frameworks in all the services that might be available. But we shouldn't be making it difficult for people to access expertise and support. We should be making it easy and right through to end of life. People affected by dementia, any aspect, need your time to listen, learn, and to be helpful. Sometimes people just want to talk, and that's particularly applicable to nearest and dearest, to partners, children. Just want to tell you how awful it is and for you to listen. They can't maybe offload to friends because, as we know, sometimes friends and family step back when there's a diagnosis of dementia in the family. So it is really helpful, in my experience, for carers, partners, children of somebody with dementia to be able to just tell you how it is, say the things that they can't say in a clinic because the person's there. And for this reason, I often meet people away from home for a coffee, just so that they can tell me what their troubles are, how they're dealing with stuff, and to try and advise if I can. And many people contact me and say, "I have a person who's young with Alzheimer's disease, for example. Do you know of any clubs that they can go to?" And in fact, not all people with dementia who are younger fit into any day centre or clubs. Some of them will need help to carry on working. Somebody might need help to manage their affairs, help them with their post, keep that with their IT skills, help them FaceTime the family, carry on their hobbies. If they're used to spending time on the golf course, it might be more helpful for them to carry on doing that with support rather than trying to find a day centre that actually doesn't suit their needs. So it's about looking at the person's lifestyle, their hobbies, their interests, their relationships, and how can those be enhanced or maintained, rather than trying to find a day centre or a club that might fit the criteria on paper. There will come a point in younger onset dementia when their needs are such that they will fit into any club or any organisation, day centre for people with dementia. But at the beginning, I think it's quite important to keep their lifestyle going as far as you can, and maybe one-to-one support could be better shaped than that. So I've raised a few points here, a very brief talk, and I hope it's been of interest, just to maybe stop and think, what is the difference for younger people, and what are we all doing, and how can we all look at or change our processes for people with dementia who are younger. That's my contact details, and thank you very much for listening.